The topic for today's presentation is resorption. It will be discussed under the following headings in the next few slides. Coming to the definition of resorption. Resorption is a condition associated with either a physiologic or pathologic process that results in loss of substance from a tooth tissue such as dentine, cementum, or alveolar bone. This was given by the American Association of Endodontists. Another definition given by Cohen says resorption affects the cementum or dentine of the root of a tooth. This resorption is also the destruction of the cementum or dentine by cementoclastic or osteoclastic action. Resorption is mainly caused due to two main factors, physiologic resorption or pathological resorption. Physiological resorption is caused mainly due to the pressure exerted by permanent successor teeth or reduced enamel epithelial cells or inherent developmental process. Pathologic resorption, on the other hand, can be due to multiple factors. It can be due to mechanical or chemical injury to the protective tissues or by stimulation by infection or pressure. Moving on to the etiology. Injury. Injury can be in the form of mechanical or chemical force, as we have mentioned earlier. The non-mineralized tissues covering the external root surface or the pre-cementum and the internal surface of the root canal, the predentine, are examples of places that the injury affects. Stimulation. Continuation of the active resorption process is dependent on a common stimulation factor of the osteoclastic cells, either infection or pressure. Its origin is different for each type of root resorption. Therefore, the various types of root resorption should be identified according to the stimulation factors. When these stimulating factors are identified, it will be possible to reverse the process by removing the etiological factor. So, various types of root resorptions can be classified according to the stimulation factors. We have pulpal infection resorption, periodontal infection resorption, orthodontic pressure resorption, impacted infection resorption, impacted tooth or tumor pressure resorption, and ankylotic resorption. Coming to pulpal infection of root resorption, which is one of the most common stimulation factor. When an injury is caused to the pre-cementum or predentine, it affects or causes infection to the dentinal tubules. This in turn stimulates the inflammatory process with osteoclastic activity in the perioradicular tissue or the pulpal tissue, and this in turn initiates external or internal resorption. Clinically, the teeth are not symptomatic, and resorption is mainly only seen in the radiograph. As the process progresses, the teeth may be symptomatic, or a periradicular abscess may develop and may also cause tooth mobility. Radiographically, radiolucency is observed, and in the external root surface, the dentine and near the adjacent bone. It is also seen in the internal root canal dentinal. Infrequently, external root resorption may occur after the injury of the pre-cementum, apical to the epithelial attachment, followed by bacterial stimulation originating from the periodontal sulcus. Injury may be caused by dental trauma, and chemical irrigation may be caused by bleaching agents such as hydrogen peroxide or orthodontic treatment or periodontal procedures. What happens is the bacteria from the periodontal sulcus penetrates the patent dentinal tubules coronal to the epithelial attachment and exit apical to the epithelial attachment without penetrating the pulpal space. The damaged area of the root surface is colonized by osteoclasts, which penetrate into the dentine through a small denuded area, causing the resorption inside the root to spread. The resorptive process reaches a supragingival area of the crown. The vascularized granulation tissue of the resorption lacuna may be visible through the enamel, showing a pink discoloration at the crown. Radiographically, the periodontal infection resorption causes single resorption lacuna in the dentine, usually at the crestal bone level. This expands to the coronal and apical direction. With progression of the process, Radiolucency may be observed at the alveolar bone adjacent to the resorption lacuna of the dentine. Coming to orthodontic pressure root resorption or apical root resorption. One complication of orthodontic treatment is the apical root resorption with injury originating from the pressure applied to the roots during tooth movement. Continuous pressure stimulates the resorbing cells in the apical third of the roots, a possibility of significant shortening of the root. The teeth are basically asymptomatic, and the pulp is usually vital unless the pressure of the operative procedure is high, which disturbs the apical blood supply. Here again, radiographically, orthodontic pressure root resorption is located at the apical third of the root, and there is no radiolucency that can be observed in the bone or the root. The treatment for this is removal of the source of pressure results in cessation of the resorption. Therefore, no root canal treatment or operative procedure is needed after. Coming to impacted tooth or tumor pressure root resorption. Pressure root resorption can be observed during eruption of permanent dentition, especially of maxillary canines and mandibular third molars. Tumors or osteosclerosis impinging on the root of the tooth could also be an etiological factor for the pressure resorption, which includes both the injury and stimulation phases. Stimulation is related to the pathologic process that activates the resorptive cells. Tumors that produce root resorption are most frequently those in which growth and expansion are not rapid, such as cysts, ameloblasts, giant cell tumors, etc. This type of root resorption is asymptomatic with vital pulp throughout the process unless the impacted tooth or tumor is located near the apical foramen, disturbing the blood supply to the pulp. Now, radiographically, the resorption area is located adjacent to the stimulation factor, that is, impacted tooth or tumor. Again, there are no radiolucent areas as no infection is involved in the process. The site is filled with the stimulation factor, that is, the impacted tooth or the ankylotic root resorption. In severe traumatic injuries, such as intrusive luxation or avulsion with extended dry time, an injury to the root surface may be so large that the healing with cementum is not possible, and the bone may come into contact with the root surface without an intermediate attachment apparatus. This phenomenon is termed as dentoalveolar ankylosis. Here, normally the bone is resorbed and formed physiologically in a remodeling process without any specific stimulation with organic tissues protecting the dentine. Osteoclasts are in direct contact with the mineralized dentine in the exposed root surface after severe trauma to the root surface. Therefore, resorption can occur without any further stimulation and the bone is laid down instead of dentine. Clinically, ankylotic teeth lack the physiologic mobility of normal teeth, and this is one diagnostic sign for ankylotic resorption. Radiographically, resorption lacunae are filled with bone, and periodontal ligament space is missing. There are no radiolucent areas observed, and at some stage the whole root may be replaced by bone. In the image that we see, there are absolutely no radiolucent areas observed, and at some stage the whole root again may be replaced by bone. There are various classifications available for resorption. The most common ones are by Engel, Cohen, Anderson, AAE, Wien, Gutman, etc. According to Anderson's classification, resorption can be classified into internal and external resorption. Internal resorption is again subdivided into inflammatory and replacement resorption, whereas external consists of surface, inflammatory, and replacement resorption. Moving to the sequence of events leading to root resorption. The first step is crushing and damage to the PDL. Loss of pre-cementum leads to denudation of the root surface. This in turn causes chemotaxis of the hard tissue, resorbing cells. Macrophages and osteoclasts remove the damaged PDL and cementum, Coming to the diagnosis, proper history of the patient must be taken. For instance, a history of fall, trauma, or accident should be recorded and found out from the patient while asking when he is on the dental chair. Crown preparation or vital tooth cutting can also cause resorption. Pulpotomy is another procedure by which resorption may. Moving to radiographic features, there is internal root resorption and external root resorption. The radiographic features for both of them differ in certain aspects. For internal root resorption, the margins may be smooth and clearly defined. For external, they're irregular and ill-defined. The root canal walls appear to balloon out for internal root resorption. The outline of the root canal is distorted, whereas the outline is quite normal for external root resorption. The root canal resorptive defect appears continuous for internal root resorption, whereas in external root resorption, root canal is seen running through the defect. Radiolucency is confined to the root and does not involve the bone, whereas it is always accompanied by resorption of bone for external root resorption. This is an example of internal root resorption. Coming to external root resorption, as we can clearly see from the radiograph, the radiolucency appears in the root and the adjacent bone, and the lesion moves away from the root canal as the angulation of the radius. Coming to the clinical assessment. Clinically, a pink spot may be seen on the tooth associated with resorption. The vitality of the tooth in question must always be checked, as if the tooth is vital, it could indicate that it is a subepithelial external root resorption or internal root resorption. In case the tooth is non-vital, it could be suggestive of an external inflammatory resorption involving an infected pulp, or it could be an internal root resorption with necrotic coronal. Advanced aids are used to diagnose resorption. They include CBCT, dental panoramic tomography, true cephalometric skull, optical coherence tomography. Moving on to the management of resorption. Therapeutic decision. The decision making must take into consideration several criteria, which includes the patient's age, tooth location, shape of the clinical crown, occlusion, resorption location, resorption vitalness, presence or absence of root perforation and their wideness, resistance or weakness of the remaining root hard tissue, periodontal status, and the ability to realize a restorative treatment of the concerned tooth. The treatment options for the following are therapeutic abstention and monitoring in absence of infectious signs and symptoms, orthograde root canal treatment with three options depending on the absence or presence of perforation on the radicular wall. They are complete root canal filling with gutta-percha on non-perforated lesions, combined gutta-percha in the root canal and MTA fillings for the perforation area, complete filling with a bioactive material such as MTA or biodentine on apical perforated lesions located in a short root length, retrograde apical treatment, extraction and replacement by implants, complete root canal filling with warm gutta-percha. Here, internal root resorption with no perforation of the canal walls is seen, and it is or it has the most favorable situation in long-term prognosis. Sealing of the internal root resorption with bioactive cements such as MTA, it is indicated in the presence of perforation of the canal walls, giving a communication between the root canal system and the periapical tissue. In such cases, MTA is used as a filling agent and it is packed at the root canal or the perforation level, and smaller the perforation size, more predictable is the prognosis. This is done so that the communication between the root canal system and periapical tissue is completely closed and there is proper healing of the perforated area. The pharmacological management of inflammatory response. There are drugs that affect osteoclasts present at the site of resorption, such as tetracyclines. There are drugs that affect the recruitment of osteoclasts to the injury site, for instance, glucocorticoids, bisphosphonates, amino acids. The combination of these two types of drugs gives a synergistic effect on the inhibition of root resorption. Thank you.